everybody, and welcome back to another video here at Whiteboard Doctor. We appreciate you checking it out. Today we are going to be talking about diabetic ketoacidosis, or DKA, and we're going to be doing more of an introductory video on DKA. What is DKA? How does it develop? What causes it? What symptoms does it lead to, and why? It's going to be a spin-off to a video we put out just recently. The thumbnail is here. And this is a video, if you go, this is our Whiteboard Doctor homepage under videos. We just put this out a handful of hours ago. This is a more advanced video on DKA versus HHS. So for those who watch this video and want to step up to the more advanced video, we'll link this in the video description, and vice versa as well. They cover slightly different things in different ways. So that is the video for today. Quick 30-second break for our introduction. Don't go anywhere though. We'll see you right back. Hello everyone, and welcome to another video here at Whiteboard Doctor. Thanks for joining us today. Here at Whiteboard Doctor, our mission is to provide you with free, interesting, relevant, understandable medical education and news for all types of lifelong learners, trainees, and practitioners. We have weekly videos that we debut Fridays at 5 p.m. Eastern Time with bonus medical education videos posted throughout the week. We'd love for you to join the Whiteboard Doctor community and follow along by hitting the subscribe button located in the bottom right-hand corner. We also encourage all likes and comments, even if it is just to say hello. All our video descriptions contain links for additional related videos that might be interesting, so don't forget to check those out. And lastly, a quick disclaimer, none of these videos are intended to be acted upon as medical advice. Please pause the video here and read this disclaimer in its entirety before moving on. With no further ado, stay well, keep learning, and let's get to the video. All right, thanks for sticking around. So to start with, we wanted to just talk about kind of what diabetes is in a simplified way, the role of insulin and glucose, because that will establish the baseline for understanding what diabetic ketoacidosis is. So diabetes is often divided into type 1 and, that was a really angled highlight, type 1 and type 2 diabetes. And this is even a simplified understanding of diabetes. There's actually multiple different subtypes of diabetes, but for the sake of this discussion, we'll kind of stick with type 1 and type 2 just to make it more graspable. Type 1 diabetes is more often seen developing in younger folks, and it's an autoimmune condition actually, where the pancreas, which is an organ in the belly that produces insulin, those cells that produce insulin are attacked and destroyed, and thus they cannot produce insulin anymore. So you get a lack of insulin in type 1 diabetes. Those cells aren't producing insulin, so you get a lack of insulin. This is distinctly different from type 2 diabetes. Type 2 diabetes in its most traditional sense is thought to develop most often later in life. Often patients have obesity or some type of metabolic syndrome. And what happens is their cells start to not respond as robustly to insulin, right? You get insulin resistance. Because insulin at the end of the day is a molecule that our pancreas creates and secretes, and our cells respond to that insulin in certain ways. So type 1 diabetes is a lack of insulin. Type 2 diabetes tends to be insulin resistance, and this will become important later. And remember, this is an oversimplification, but generally speaking, this is kind of the context, the foundation for which we understand these two types of diabetes. So we're talking a lot about insulin, right? Insulin resistance, lack of insulin, type 1, type 2 diabetes, but why exactly does that matter? What is the connection to glucose, to sugar, right? We always talk about glucose with diabetes. What's your glucose? What's your glucose? Well, glucose is simply sugar, as we know, and there's different types of sugar, but glucose is one of those. And glucose's big role, the reason it is so critically important, is because it is what prompts the most highly productive energy cycle, the Krebs cycle, in the human body, right? So glucose is a huge energy producer, all right? It's the most efficient energy producer that we have in our bodies. So you need glucose. No, you mostly need glucose to survive. But to use that glucose, to use that energy, it has to go from the extracellular space, so outside of the cell, to the intracellular space, to inside the cell, because inside the cell is where the cycle happens to change glucose into ATP, into energy. But glucose is an osmotically active molecule. Osmotically active means it can't just cross through cell membranes, right? So if glucose is on the outside of the cell, it would just bump off the cell membrane. It can't just cross into it. So what you need then is you need a transporter. You need something to come put a hole in the cell membrane and let glucose through into the cell. All right, it can't just kind of go through the cell membrane. Well, that's where insulin comes into play. Insulin prompts this GLUT4 transporter and other GLUT transporters. And what insulin does is insulin signals the cell, right? Insulin says, hey, we got glucose outside the cell in this extracellular space. Let's get that GLUT4 transporter or other GLUT transporters in the cell membrane, all right? And let's transport glucose into the cell. All right, and once it says that, that glucose starts traveling into the cell. You get more glucose in the cell, right? And then this prompts energy production. So that puts glucose kind of into those energy cycles to create energy for the human body to function, right? That is why insulin is so important, because without insulin, type 1 diabetes, no insulin, or type 2 diabetes, where these cells don't respond as much to insulin. Insulin says, hey, I'm here. Put the GLUT4 transporter in the cell membrane, and the cell goes, nah, I don't really recognize you as much. Instead of putting 5 transporters in there, I'll just put 1 in there, right? So there's still some insulin around in type 2 diabetes, but the cells don't respond to it as robustly. And without this insulin, you can't get glucose into the cell efficiently. And without getting glucose into the cell efficiently, you can't make energy, at least not the most efficient way. All right, so that is why diabetes is so critical. That's why insulin is so critical. Right? And the reason that in diabetes your sugars go up, the sugars you're testing are all extracellular, right? You're testing it from your bloodstream. So if you can't get glucose to the inside of the cell because you don't have insulin or you have resistance to insulin, then you're just going to get more and more glucose outside the cell as you eat because it can't go inside the cell to get metabolized. And that's when you get the hyperglycemia, the high glucose in your blood, right? Okay, so now that we have established that, hopefully that makes sense. Certainly let us know in the questions if it does not. We're going to transition into, well, what happens when we develop diabetic ketoacidosis or DKA? Well, so usually with diabetic ketoacidosis, let's say you have diabetes, right? And you have diabetes, you're taking your insulin, your glucose is okay because you're taking your insulin, and your insulin is bringing that glucose from the outside of the cell to the inside of the cell, you're producing energy, all is well. But then you get sick, or you drink too much alcohol, or you have pancreatitis, or you have a heart attack. All those are considered what we call a precipitating factor. In precipitating factors, what happens is these alter the amount of insulin you need to then use the glucose you have in your body. And that precipitating factor then can lead to insulin resistance. And when you get insulin resistance in a diabetic who depends on that insulin, that can then tip you over into DKA. And we're going to talk more about exactly how this happens, but it starts with a precipitating factor. And the way I like to remember precipitating factors is the 4 I's, right? So we'll draw 4 I's, 1, 2, 3, 4. And the first I is ischemia. Ischemia just stands for lack of blood flow. And this is supposed to, be a hint for things like myocardial infarction or heart attacks, pulmonary embolism or blood clots in the lungs, even acute limb ischemia. We'll just put ALI, acute limb ischemia, where you get a blood clot in one of the arteries of the leg or arm and it causes ischemia or lack of blood flow to the arm. So any ischemic insult can be a precipitating factor because what this does is it makes you sick. And when we get sick, the body is less responsive to insulin, just in general, even people without diabetes. And when your body is less responsive to insulin, but you're a diabetic, depending on the insulin you're giving yourself, your body can't then, crank up the amount of insulin it's producing. So let's just do a thought experiment. Let's say I'm over here. This is me. I don't have diabetes. I have a heart attack, a myocardial infarction. I get sick. My pancreas, which is going to be this little squiggly organ here. Hi, I'm the pancreas. Smiley face. My pancreas is going to go, oh, I'm sick. I'm going to increase the amount of insulin I'm producing. So I increase the amount of insulin I'm producing. So then my cells, who are saying before I increase the amount of insulin, it's telling my cells saying, hey, let's transport more glucose into the cell. And the cell's going, no, I'm sick. I'm not going to be as responsive to you. All right, but then my pancreas says, wait, come on, we need to put glucose into the cell. So I'm going to increase the amount of insulin I'm producing. And then the cell sees that more insulin and goes, all right, I'm putting the transporter in. Let's bring the glucose into the cell. But now let's say my friend has diabetes, right? And they have a heart attack. Their pancreas can't produce insulin, right? Their pancreas is a little sad. Or they have type 2 diabetes, so they already have some insulin resistance. So what they're doing is they're giving themselves a set amount of insulin. So when their cell is sick and the insulin they're giving themselves comes in and says, hey, we need to transport glucose into the cell, and that cell goes, no, I had a heart attack, I'm sick, I'm not listening to you, their pancreas can't increase the amount of insulin they're producing. So that insulin resistance starts to lead to less glucose going into the cell because you're not putting that transporter in the cell wall because the cell is sick and not responding to the insulin you're giving yourself as much. You can't get more, your pancreas isn't able to produce more insulin. And thus you start to get hyperglycemia. You start to not be able to get glucose into the cells. And that can prompt this DKA spiral, which we'll talk more about. So that's ischemia, right? The other I. And this process is the same for all four of these precipitating factor I's. It's just all these things can make you quote unquote sick and make you more resistant to the insulin you're giving yourself. So another I is anything that can cause kind of whole body inflammation. All right. This is things like pancreatitis or inflammation of the pancreas, hepatitis, pneumonitis or inflammation of the lungs, hepatitis, inflammation of the liver. Anything that can cause whole body inflammation can be a precipitating factor that leads to insulin resistance and diabetic ketoacidosis. This I always put ingestion, and this is kind of meant to be substance use, drugs, alcohol, all that kind of stuff. And then the last I is infection, and infection is a big one. When we get sick, when we're infected, we have pneumonia, we have a skin infection, we have a urinary tract infection. All those infections can lead to insulin resistance and DKA. So this is kind of how I remember the precipitating factors, the four I's. But it's really anything that can kind of make you acutely ill, can tip you into diabetic ketoacidosis. And then another big one, for some people, certainly not others, is medication noncompliance. Obviously, if you stop taking your insulin, you're at risk for going into DKA. So does that make sense? It usually starts with someone with diabetes who then has a precipitating factor. They stop taking their insulin or they get sick, and then that leads to them having insulin resistance. Since their pancreas can't produce more insulin the way your and I's can, they start to not be able to transport glucose into the cell because the cell isn't responding to the insulin that they're taking, and that leads to hyperglycemia and DKA. So then what exactly is happening when you go into DKA? What is really that process? What are we looking at? Well, when we go into DKA, a couple things happen, and this is, we already talked about part of this. So let's just say, for the sake of ease of understanding, we stopped taking our insulin. So our body is without insulin. We're type 1 diabetic and we stopped taking the insulin we're supposed to take. So we're not, our body is essentially not getting any insulin. Our pancreas can't make any, we're not taking it. So then you get no GLUT4 transporters, right? And without GLUT4 transporters, you can't transport any of the extracellular glucose into the cell, at least not any in an efficient way. So then you're not getting intracellular glucose, right? And as we talked about, if it's not just from not taking your insulin, let's say you get sick, you have that stress or that precipitating fact. So then you get insulin resistance. Your cells stop responding to the insulin you're taking. And again, then you can't put that transporter in the cell membrane. You can't transport that glucose into the cell. So then that glucose stays extracellular. Without any intracellular glucose, you can't use that glucose for energy metabolism in the same way, right? Because that glucose needs to get into the cell and then it can participate in energy production. And that is really what starts to cause all these downstream effects, all right? You start to get hyperglycemia because, actually we'll talk more about that in a bit. The first downstream effect I want to talk about is ketosis. But for the sake of understanding, I want you to think about kind of three downstream effects that we'll talk about. Dehydration is one of the things that starts to develop. High glucose in the blood or hyperglycemia, and acidosis. And with this acidosis, we're going to actually put a slash here and say acidosis and ketosis. And this might not make perfect sense right now, but hopefully it will shortly. All right, so think about those three things. So the first thing we're going to talk about is your body starts to get acidosis and ketosis. So why is that happening? Well, that's happening because we cannot get glucose into the cell to make energy, right? We cannot use glucose to produce energy. So your body goes into panic because glucose is the most efficient way to produce energy, right? The way that happens, this might look familiar to some, maybe not to others, but this is the main pathway for glucose to produce energy. It gets converted into acetyl-CoA. That goes into the Krebs cycle, which has really efficient energy production. But this glucose has to get into the cell. So you're in DKA, you don't have insulin or you're resistant to insulin, so you can't transport that glucose into the cell. So this goes away, right? You're no longer able to make that glucose into acetyl-CoA, so you can't use the Krebs cycle with glucose and you can't produce energy. And that's really bad, right? You need energy to live, for your brain, for your heart, for your organs to work. Your body says, well, shoot, I'm going to die if I can't find another way to produce energy. So the way it does that is it starts to say, okay, what I need is this molecule, acetyl-CoA. I can't use glucose to make it, so I'm going to start to break down my fats, my fatty acids. I'm going to oxidize them because that can also produce acetyl-CoA. And then if I can do that, I can make the Krebs cycle work again and I can produce energy. So the body starts to break down fatty acids. It's like, have you ever heard of the ketone diet? And this is certainly not an endorsement for the ketone diet, but that's what happens. You don't have enough glucose, so your body starts to break down fatty acids to make energy, right? The reason it's called the ketone diet is because the byproduct of that is something called ketosis. Because when you oxidize and break down these fatty acids, yes, acetyl-CoA will result, but also ketones will result as a kind of byproduct of that. Things like BHB, which is beta-hydroxybutyrate, and then ketones themselves. The thing about these molecules...
BHB is one of three ketones.
Well, my Siri decided it was going to spy on me and talk about ketones, but sorry about that. The thing with these ketones as byproducts of this, what you need to do if you can't use glucose, right, to make energy, is that they're molecules that cause an acidosis. They're these negatively charged organic anions, which causes an anion gap acidosis. And just another quick shout out to other videos on the channel. We have a great series of acid-base lectures we put together. I wonder if it's even how long ago it was, if it'll come up on here. Here they are, acid-base lectures. If you want to brush up on acid-base, this is a great series. We'll link it in the video description. All things acid-base there, so definitely check those out if you want to learn more about acid-base. But it causes this anion gap acidosis. And the acidosis is what can make you really, really sick in DKA, right? Your blood becoming more acidic means that the proteins and enzymes and everything can't work as well as they usually do. And if you're on the ketone diet and you need to do a little oxidation of fatty acids to make acetyl-CoA to make energy, fine. You form some ketones, but not enough to really cause your body to go into organ failure. Whereas if you're in DKA and you have overdrive oxidation of fatty acids because you're not able to use any glucose, and you go into profound ketosis and profound acidosis, this is what can kill you. You can die from this in DKA, this profound acidosis. And that's all because you don't have insulin or you have too much insulin resistance, leading to no glucose being able to get into the cell, leading to inability to make energy with glucose, right? This whole side of the equation's crossed out. So then you start to oxidize your fatty acids, break down your fats to make acetyl-CoA, to produce energy, with the byproduct being these ketone bodies that cause an acidosis. What else happens? So we said these three things, right? Acidosis, ketosis, we talked about. But why do you get more and more hyperglycemic? It doesn't make sense. Most people in DK feel really sick, right? They're usually not eating or drinking much. They got nausea and vomiting. Why do they get more and more hyperglycemic? Why does their glucose go up and up? Well, what happens is your body, without insulin, is fooled into thinking it doesn't have any glucose, right? because even though the glucose in your blood is high, you're not able to get that glucose into the cell. So the body is tricked into being like, wait, I don't have any glucose. I need to make more glucose. I need to do everything I can to make more glucose and get that glucose to the most important areas of the body. So it does a couple things, and we won't dive into the nitty-gritty details of all these processes, but it goes through glycogenolysis, right? Glycogenolysis breaks down glycogen into actually more glucose. So you start to get more serum glucose, right, which leads to higher glucose in your blood. It also does gluconeogenesis. The details of this are escaping me right now, but also leads to more circulating glucose, which again leads to more hyperglycemia. And then it starts to cause your peripheral tissues to use less glucose because your body's like, shoot, I don't have any glucose. Whatever's there needs to go to the most important organs, my brain, my heart, those other things. Muscles and all that, forget about them. So it starts to decrease the peripheral utilization of glucose, which then leads to, again, more glucose. So that is why you get more and more hyperglycemic in DKA. You get more and more circulating glucose. When you test your sugars, it's going up and up and up, even though you're not eating anything, even though you're not increasing the amount of sugar in your body from oral intake. Your body is tricked into thinking it doesn't have any glucose. So it starts to prompt all these different cycles to increase the serum glucose as kind of a panic response to try to salvage what they think is a lack of glucose, whereas in reality, it's a lack of insulin or insulin resistance, fooling the body into thinking it's a lack of glucose. So that is why you get more and more hyperglycemic. So now we talked about how you get acidotic and ketotic, right? It's because you're metabolizing your fatty acids to try to produce energy, and those fatty acids byproducts, being ketone bodies, lead to acidosis. We talked about why you get more and more hyperglycemic. Your body is fooled into thinking it doesn't have enough glucose, so then it starts to prompt all those signaling cascades to increase the amount of circulating glucose, but you can't use any of it because it's really a lack of insulin. What about dehydration? Why do you get so profoundly dehydrated? All right, that's kind of it leads to more stuff in this, but kind of the main three things. Why do you get more and more dehydrated? Well, it's actually related to the hyperglycemia. So if you remember, I mentioned that glucose is osmotically active. And it means, a lot of you probably know what that means, but what it means is it pulls water with it. So water follows glucose. If you were to do an experiment, you were to put a permeable membrane and you were to put, I don't know, let's say 80 glucoses on one side, and you were to put 2 glucoses on the other side, and then you filled both sides with water, the water would travel towards the higher concentration of glucose. It's osmotically active. Well, why am I even saying that? Why does that even matter? Well, I'm saying that because our kidneys filter the blood, right? Makes urine. And what happens in the kidneys, I'm just going to draw, this is a glomerulus and a nephron. If you're not familiar with what those mean, within the kidneys itself, there's all these kind of tube systems that filter the blood and produce urine, and they reabsorb different things like electrolytes, protein, glucoses. And there's the proximal tubule, Lupa Henle, distal tubule. Again, not going to dive into all that in this lecture, but what to note is that when we're hyperglycemic, we have all this glucose in the blood, right? And the blood, well, we'll do red. The blood is here, the blood filters in, and then some of the blood gets filtered into the actual kidney tubule. And when our glucose is that high, obviously you get a bunch of glucose in the kidney tubule that filtered in. But the kidney usually reabsorbs all this back into the bloodstream because glucose is important. It says, no, I don't want to urinate out that glucose. And for the sake of the drawing, this is all urine, right? This is the tubules that all kind of come together that end up producing the urine that we pee out. But the body says, no, glucose is important. I don't want to pee out all my glucose. I'm going to reabsorb it, right? But we said it's osmotically active. So to reabsorb it, the kidney has to actually transport it. It can't just diffuse through the membrane, the wall. It has to transport it back into the blood. Well, when we're so hyperglycemic, those transporters get saturated because they can only work so quick. And that usually happens between Glucose concentration is at 200 to 300. I forget the units on here, but it's something per deciliter, maybe milligrams per deciliter or something, but 200 to 300. And after that concentration, there's not enough transporters, so you start to maintain glucose that stays in these tubules. But we said it's osmotically active. So what happens to all kind of the water that the kidneys are reabsorbing back into the blood? Well, that water stays in the tubules and ends up getting urinated out. So we start to urinate out large amounts of glucose in water, and it causes what we call osmotic diuresis. Osmotic being you have this osmotically active molecule being glucose, and diuresis meaning it causes us to pee more. So even though we're dehydrated and our kidneys should be reabsorbing all this water, they can't, because these tubules are full of glucose that the kidney could not reabsorb back into the blood because the glucose concentrations are too high. The water gets pulled in to these tubules, and then your kidneys pee out all this water and glucose. And this is a self-perpetuating cycle. Why is Siri's really spying on me today? This is a self-perpetuating cycle, because as you get more dehydrated, you become more resistant to insulin, right? If we're sick, we're resistant to insulin. So then your body gets more and more hyperglycemic and acidotic, and then you start to pee more and more fluid out. So it's this self-perpetuating cycle that makes us sicker and sicker. It causes electrolyte derangements as well, so kind of dehydration and light electrolyte derangements occur. And this can be really, really serious too. So these are kind of the three main manifestations of DKA as explained. So hopefully we understand them better. And this is why people in DKA often are very thirsty. They're peeing a lot. They get abdominal pain, nausea, vomiting, lightheadedness, weakness. All of those symptoms are manifestations of the things we talked about. So that's all we have for you today. Hopefully that was helpful or interesting. Hopefully it's a more kind of well-versed and comprehensive introductory lecture compared to the more advanced video we put out yesterday. Definitely check out that video, though, if you feel like you've mastered these topics and you want to dive into a more advanced understanding. Let us know what thoughts, comments, questions you have down below. Definitely check out our other videos, subscribe, hit the bell button, all that good stuff. We appreciate you all. Stay well, keep learning. We'll see you next time.